I welcome everyone here from all around. I thank you for the privilege of speaking with you on a Saturday, and thank you for the invitation from the American Academy of Orofacial Pain to lead this series off. I think it's a very important series for us to appreciate the things that have happened in our profession and how we've got to this specialty and what this specialty is all about. So I have the privilege, and I've been here long enough that I can watch this history. And so some of this may be a little more personal history. But what I want to do in this next hour or so is I'm pretty ambitious this way, because what I really want to do is let me get this thing going here. So I want to give you some information, and I'm going to categorize it here. Like, for instance, we're going to talk about what is orofacial pain. How did this all begin? I want to give you some of the history, and some of that will be my personal history because I've lived through this for quite a while. Why is it important? Why should we have a specialty in orofacial pain? You've heard about this. It's the most recent oral space. Is it necessary? Well, let's talk about that. And what do orofacial pain clinicians really do? What do they practice? Who are these specialists, and how do we get the training? And the importance of a multi-professional, multidisciplinary care. I want to talk about that. And talk about how it is that you, if you're not into this area, might learn more about it. And Dr. Mullet just gave you some examples of that. We'll talk about that. Let's start with number one here. What is orofacial pain? Well, actually, it's a pretty easy, simple definition. Orofacial pain is a general term covering any types of pain felt in the face, the mouth, the jaws, the face, etc. So that's a broad term, isn't it? It is. So where did this all begin? Now, here's where I want to share a little bit of the experience I've had watching this development, because there's been many people in the background interested in this becoming a specialty, but it's taken us 30, 40 years to get this kind of recognition. So where has this all begun? I think it began because many of us in the profession were looking at answers, and the answers that we were looking for weren't necessarily answers that seemed to have the evidence base that we need. So, and when we're looking for information, as I was perceived this, from my perspective, we really began in two parallel worlds. What I mean by that is we had two worlds of groups of individuals, and one of those was the mechanical world of dentistry. And this is what we're trained. And we knew about certain ways to build the mouth back again. So it was a very mechanical history of dentistry. But then we also had a very poorly understood world of pain, which we were not very intuitive, very much involved in. In fact, most of pain in general has become very, very better understood and documented in this last number of years. But these two worlds. So how do I relate this? Well, if you take a look at dentistry, way back in 1926, there was the foundation of the National Society, and Beverly McCullen at that time was considered to be one of the fathers of gnethology. And after that, we started to see Harvey Stoller start talking about gnethology. So this was our world of dentistry. And it was about how we could replace teeth and how we could do the dentistry necessary for our patients to function, chew, swallow, and speak. But interesting enough, at that same time, on the other side of this poorly understood world of pain, an otolaryngologist from St. Louis, James Costin, started noticing in his patients that, in fact, they have ear pain, but there's no ear disease. But he then would put little pieces of cork between the teeth of the patients, and they would say, boy, that feels better. And so he defined this in 1934 as a condition, which then became Costin syndrome. And so it was the first time we started seeing people start to be concerned about pain in the face that might not be related, that could be related to dental issues, I would say. So then we progressed a little further, and then we started to seeing our profession of dentistry really take off with gnethology, with fixed prosthetics, fully adjustable articulators, full mouth reconstructions, which were things that patients might have needed at that time. So we see names like Charlie Stewart, Peter K. Thomas. A lot of the Southern California groups got together, very strong groups in gnethology. At the same time, there were some things going on in the poorly understood world of pain. And here are two examples of Charlie Green and Dan Laskin, who got together and questioned what was the etiology of the pain issues that our patients were suffering from. And it was at that time that I entered this area of this field of orofacial pain. And so I started my journey in this in 1974 when I became a full-time faculty member at the University of Kentucky. Been a few years ago. And I was told, I was asked to teach the area of occlusion. So I did that. But the mentors that I was looking for to help me understand this better were not the kinds of mentors that we see these days anyway. They were mentors that were charismatic, interested, knew what they were talking about in the area of dentistry, but they couldn't answer all the questions. And so one of these examples, I'm just using Niles Gachet as an example. And Niles Gachet developed a fully adjustable articulator. And what was happening is we were linking this dentistry into the field of pain. And at the same time, we have Chuck Green again and Dan Leskin doing some studies saying, you know what, I'm not sure this link is as strong as we once said. But when you go to the mentors that were in the dental side of this thing, I went to these mentors in the early 70s or late 70s and asked the question, sometimes I have these patients and I get their bite really looking good, but they still have pain. What do we do? And the answer I received was, well, that doesn't happen to me. If you do it right, you solve all the pain problems. And I said, really? And it just didn't seem like that was the magic answer. And so other individuals start to orient themselves towards this pain. And I'm mentioning a few names here. I can't mention them all, but John Rue, as a psychologist, giving insight. Glenn Clark, Southern California. Jim Frickton, Minnesota, trained in California, same time. These individuals started coming together and said, wait a minute, this field is bigger and broader than the tops of teeth. And so because at that time, what we were saying to ourselves is we have patients who have malocclusions, we have patients who have pain, and the two of those are equal. If you have a malocclusion, it's going to cause pain. If you have pain, it's because your malocclusion is there. We got to fix that. And then what happened to us is we started to look at evidence-based dentistry. And when evidence-based dentistry came up, we said to ourselves, wow, maybe that relationship isn't nearly as strong as we once thought. And so we started to migrate. And what we started to see at that time is this mechanical world of dentistry and the poorly understood world of pain started to come together and clash. And all of a sudden, it became obvious to many that we have to look at this better to understand the relationship. And at that time, we start to see the individuals who spent all their time in dentistry understanding the role of occlusion. And is that the reason why we have pain? So we have the believers there, and they were the ones that were very occlusally aware. We can solve people's problems if we got the bite right. But they were being challenged at that time by the other group. And the other group was maybe a biopsychosocial group saying it's bigger than that. It's not only occlusion. Maybe it's not even occlusion. And so we had these debates going on, very, very passionate debates, defending the belief model. And so we had to ask ourselves the question, here's our normal functioning patient. Do they have perfect bites? Do they have everything? Well, what gets them over here to TMD, temporomandibular disorders, to become a patient? What's the etiology? What brings them from this stage of normal function to a problem? And what we said, well, when you look at etiological factors, we'd already convinced ourselves professionally, we knew what it was occlusal factors. But the more and more we started to explore occlusal factors, the more we realized maybe that's not everything. Maybe there is something about this emotional stress, the biopsychosocial history, and how emotional stress can affect how our jaw functions, how our whole central nervous system functions, if you will. Or maybe what it was is something even different than that, bruxism. Maybe what if we could stop people from bruxing? There's our reason for face pain, And was that related to occlusion or not? Of course, we had belief models there that have been discarded as we start to look at really the mechanisms of parafunctional activity, bruxing, clenching, and such. And then we said, well, wait a minute, there's more etiologies. There's even trauma that could cause some of these conditions that isn't related to dentistry at all. And then we started to say, well, wait a minute, there's also some interesting things happening with deep pain input. Because what we now appreciate is when we have deep pain, whether it's a toothache, whether it's muscle pain, joint pain, whether it's cervical pain, whether it's any kind of pain, what we start to see that the central nervous system now becomes a major player in what's going on with this patient's pain experience. And so then we start to introduce, wait, there's a big central nervous system and how it influences this, which becomes very important. So enter the idea that orofacial pain is much more than just TMD, musculoskeletal pain, temporomandibular disorders. Well, so we started to develop clinics. I started our clinic in 1977, and it was a clinic that was going to be a multidisciplinary clinic. And it was there for what I call the non-responders. I put this together because there were patients that had pretty good bites, or we had changed their bite and they were no better. So the question is, what's going on here? So we started this clinic, and at the same time, we were seeing clinics in California and UCLA and Minnesota developing the same kind of concepts about, let's see what else is happening here that we can help our patients with. And I was looking for a mentor at this time, and this is maybe a little more personal thing for me to talk about, but I think it's part of what developed here. And I found this person, Dr. Weldon Bell, an oral surgeon in Dallas, Texas, had written two marvelous textbooks, one on TM disorders, one on orofacial pain. And I started to gain knowledge from his knowledge in that. This is a picture of Dr. Bell and I on his 80th birthday in the Equilibration Society. And I remember this is one of the quotes he told me. I'll never forget this. He said, "Follow the man who's seeking truth, not the man who has found it." You see, there are many individuals that you'll meet that believe what they know is the truth, and they carry that on very emphatically. And yet sometimes it's not the truth. And sometimes you go to your mentors and you ask the questions and they're giving you information, but follow the man who's seeking the truth. And when truth is uncovered, follow those leads. And we needed to do that in orofacial pain because orofacial pain is complicated. He also said something else to me. He said, think for yourself. The teacher may be wrong. That's a powerful statement. I mean, Dr. Bell was my teacher. Why would I doubt him? Well, no, if we really care about patients and understanding these problems, we have to continue to doubt in a respectful way as we uncover the truths that we're dealing with. So what we started to understand is that all pain in the face is not TMD, not temporomandibular. There's lots of reasons for pain in our faces that we need to be appreciating and understanding in order to help our patients. So I like to look at pain conditions in dentistry and put them in one of three categories. We've got dental pain, we got pulpal pain, and we know how to do that. We are fantastic at solving dental pains. We're 93% successful by doing root canals and extracting teeth. That pain will be gone in a day or two. We don't need to talk about that. Every dental school teaches us well, and we do that. But you also have periodontal pain. These are the odontogenic sources of pain. And we absolutely have to know about this as dentists because these patients come to us and we're the only healthcare provider that will solve those problems. Well, we've got those under control. In fact, we got that under control. Let's go to the second group, which is temporomandibular disorder pain. That's the second group of pain conditions that we dentists need to face. So let's define TM disorder, what a TM disorder is. It's a collective term, embracing a number of clinical problems that involve the masculatory musculature, the temporomandibular joints, and associated structures, or both. That is the definition that we have from the American Categorizing Pain Guidelines, which I'll talk about in just a bit. Okay, so if somebody calls me up and says, Dr. Okeson, I've got a temporomandibular disorder patient, what is that? It's musculoskeletal pain disorders in the masculatory structures. That's the definition of temporomandibular disorders. And then the next question is, well, is that important for us? Yes, it's important for we dentists. Dr. Horst did a survey of patients in the Northwestern area, or the North Pacific area, and asked patients, when the last time you went to the dentist, why'd you go to your dentist? In the last 12 months, 1 out of 6 patients went to a dental office because of pain. They had pain in their face. Okay, well, what's the most common pain? Well, it's toothache. But following toothache, pretty closely following it, was musculoskeletal pain. The second most common pain complaint we face in dentistry with our patients is musculoskeletal pain. So is TMD important? Yes, it's very important. The second most common reason, if they're in pain, that they're going to come to us. We have to understand that. But we've done a pretty poor job in dental schools doing that. Now, recently, finally, after 30 years of battle with the Commission on Dental Accreditation, we now have a ruling that says every dental school has to teach some TMD. Absolutely essential, because we are the only healthcare provider that's going to solve patients with musculoskeletal pain in the masculatory system.